Coming to the next set of charts. So these are the insulin regimens. So long standing insulin is given in the night like Largen or Detamir, and short acting insulin are given in the morning, afternoon and evening in case of pulse therapy after the food. Then morning insulin analog, afternoon, evening and night. So intermediate acting is given during the morning and in the evening, followed by regular insulin or short acting insulin in the morning and the evening. So this is the second regimen. And the last one is you give a basal infusion of insulin via infusion pump and increase the dose of or give a bolus dose just before food. There is morning, afternoon and evening, and throughout there will be a basal infusion of insulin. Diabetes related complications, microvascular, macrovascular and other complications. Microvascular, it is retinopathy, non-proliferative proliferative macular edema. Neuropathy is sensory and motor symptoms, and autonomic neuropathy. Nephropathy, there will be albuminuria and declining renal function. Macrovascular complications include coronary heart disease, peripheral arterial disease and cerebrovascular disease. Other include gastrointestinal like gastroparesis and diarrhea, genitourinary like uropathy and sexual dysfunction, dermatologic, infectious, cataract, glaucoma, cherioarthropathy, periodontal disease, and hearing loss. The patient with type 2 diabetes, individualized glycemic goal, medical nutrition therapy, increased physical activity, weight loss plus metformin, reassess HbA1c, combination therapy with metformin plus second agent, reassess HbA1c, combination therapy with metformin plus two other agents, reassess HbA1c, insulin plus metformin. So it is very important, even though you are sending a patient on metformin, on insulin, it is always very important to add metformin in case of type 2 diabetes mellitus to counteract the insulin resistance, and also it reduces the effective insulin dose required. Coming to a very important chart, that is hyperglycemia associated autonomic failure. One is early type 2 diabetes mellitus, that is relative beta cell failure. There is marked absolute or therapeutic hyperinsulinemia, falling glucose levels, and isolated episodes of hypoglycemia. So in advanced type 2 DM or type DM, advanced absolute beta cell failure, there is relative or mild moderate absolute therapeutic hyperinsulinemia and falling glucose levels. When beta cell failure, there is no insulin and no increase in glucose, no decrease in insulin. So the first response towards autonomic failure is there is no decrease in insulin and no increase in glucagon. So there are episodes of hypoglycemia. During exercise and during sleep, there is attenuated sympathetoadrenal response to hypoglycemia. So there is decreased adrenal medullary epinephrine response and decreased sympathetic neural response. So there is defective glucose counter-regulation and there is recurrent hypoglycemia. There is hypoglycemia unawareness due to decreased sympathetic response, which is aggravated by if the patients are on beta blockers. Many of them are because they already have cardiovascular disease along with diabetes, so they are on beta blockers, which further masks the sympathetic response and causes recurrent hypoglycemia. So management of type 2 diabetes, individualized glycemic control like diet, lifestyle, exercise and medication, treat associated conditions like dyslipidemia, hypertension and obesity, screen for or manage complications of diabetes like retinopathy, nephropathy, neuropathy, cardiovascular disease and other complications. Causes of hypomagnesemia, excessive magnesium intake like cataracts and urologic irritants, parenteral magnesium administration, rapid mobilization for soft tissues like trauma shock and sepsis, cardiac arrest and burns, impaired magnesium excretion like renal failure, familial hypocalciuric hypercalcemia. Others are adrenal insufficiency, hypothyroidism, and hypothermia. Causes of hyperphosphatemia: impaired renal phosphate excretion, that is renal insufficiency, hypoparathyroidism. It can be developmental, autoimmune, after neck surgery or radiation, activating mutations of the calcium sensing receptor. Parathyroid suppression, which can be parathyroid independent hypercalcemia, vitamin D or vitamin A intoxication, sarcoidosis and other granulomatous diseases, immobilization and osteolytic metastasis, Milk-Alkley syndrome, severe hypermagnesemia or hypomagnesemia, pseudohypoparathyroidism, acromegaly, tumoral calcinosis and heparin therapy, massive extracellular fluid phosphate levels, rapid administration of exogenous phosphate, that is IV, oral or rectal, extensive cellular injury or necrosis like crush injury, rhabdomyolysis, hyperthermia, fulminant hepatitis, cytotoxic therapy, and severe hemolytic anemia. Transcellular phosphate shift, that is in metabolic acidosis and respiratory acidosis. Physiologic response to decrease in plasma glucose concentration. Decrease in insulin when the blood occurs when the blood glucose is around 80 to 95. It causes increased lipolysis, increased free fatty acid and increased glycerol. It is a primary glucose regulatory factor. It is the first defense against hypoglycemia. So if you remember, first defense is against hypoglycemia is decrease in insulin and not increase in counter-regulatory hormones. Increase in the glucagon levels, that is primary glucose counter-regulatory factor. Second defense against hypoglycemia occurs when glucose level is between 65 to 70. After glucagon, there is increase in epinephrine. It happens when glucose levels are between 65 to 70. There is increased lipolysis, increased free fatty acid and glycerol. It's the third defense against hypoglycemia. Increase in epinephrine is very important when glucagon is deficient. Increased cortisol and growth hormone. It occurs when the glycemic threshold is between 65 to 70. It is involved in defense against prolonged hypoglycemia. It is not critical. Symptoms occur 50 to 55. Recognition of hypoglycemia. There is prompt behavioral defense against hypoglycemia, that is food ingestion. Decreased cognition occurs when blood glucose levels are less than 50. That is compromises behavioral defense against hypoglycemia. So this is again a very important chart to consider. So guidelines for ongoing comprehensive medical care of patients with diabetes, individualized glycemic control and therapeutic plan, self-monitoring of blood glucose, individualized frequency, HbA1c testing 2 to 4 times per year, lifestyle management and care of diabetes, including diabetes self-management, education and support, nutrition therapy, physical therapy, psychosocial care, including for evaluation of depression and anxiety. Detection, prevention and management of diabetes-related complications, including diabetes-related eye examination, which can be considered annually or biannually, diabetes-related foot examination 1 to 2 times a year by provider, daily by the patient, diabetes-related neuropathic examination will be annual, diabetes-related kidney disease testing will be annual. Management or treat diabetes-related relevant conditions, including BP, assessed quarterly, lipids, consider antiplatelet therapy, influenza, pneumococcal and hepatitis B immunization. So when there is decreased arterial glucose, by the pancreas there is decreased insulin and increased glucagon, which again acts on the liver to increase the glucose production, which will increase the arterial glucose. Okay. Now, when there is decreased arterial glucose, the brain will increase the sympathetic outflow, which will send signals to the adrenal medullae, which will increase epinephrine, which will ultimately increase glucose production. Epinephrine will also act on the kidneys to increase the glucose production. When the sympathetic outflow will stimulate the sympathetic postganglionic neurons and will cause increase in norepinephrine and increase in acetylcholine, and which will lead to increase of ingestion. Now, in the muscle, there will be, by increase in epinephrine and increase in norepinephrine, There will be increase in gluconeogenic precursor, that is lactate, amino acid and glycerol. There will be decreased glucose clearance, will lead to increased arterial glucose. By the pituitary, there will be increased release of growth hormone and increased release of ACTH, which will ultimately act on the adrenal cortex and increase in the cortisol. So this is the overall mechanism of decreased insulin and increased glucagon, or mechanism of action for rapidly or preventing correcting hypoglycemia. Diabetes complications, it can be microvascular, macrovascular and other complications. Microvascular complications is diabetic retinopathy and macular edema. So neuropathy, that is motory and sensor and autonomic neuropathy, and nephropathy will cause albuminuria and declining renal function. Macrovascular complications of diabetes are coronary artery disease, peripheral arterial disease and cerebrovascular disease. There is CVA. Other complications include gastrointestinal, it is gastroparesis and diarrhea, genitourinary infections, uropathy and sexual dysfunction, dermatological complications, infectious cataract, glaucoma, chorioarthropathy, periodontal disease and hearing loss. So these are the most common complications of diabetes. So, coming to a very important topic, manifestations of diabetes ketoacidosis, DKA, that is diabetic ketoacidosis. Symptoms are nausea, vomiting, thirst, polyuria, abdominal pain and shortness of breath. Precipitating events are inadequate insulin administration, infections like pneumonia, UTI, gastroenteritis and sepsis, infarction like cerebral, coronary, mesenteric and peripheral, certain drugs like cocaine, very important, pregnancy. Physical findings, patients will have tachycardia, dehydration and hypotension, tachypnea, small respiration, very important, respiratory distress. Abdominal tenderness may resemble acute pancreatitis or surgical abdomen, lethargy, obtundation, cerebral edema and possibly coma. So treatment for goals for adults with diabetes, one is glycemic control. HbA1c should be less than 7. Preprandial capillary plasma glucose should be around the range of 80 to 130. And postprandial glucose should be less than 180. Blood pressure should be less than 140 by 90 millimeters of mercury. Very important chart.